Melanoma is not just one disease. It's probably at least 3 diseases based on the molecular characteristics of the tumors. And we've been studying this since the early 2000s, looking at both the risk factors for the different types of melanoma, the best ways of diagnosis, and outcomes from different types of melanomas, along with the best treatment options. And so how a patient is treated now is determined by what subtype of melanoma they have. We have been looking at the best ways to find out what subtype they have, and one of the initiatives of the Cancer Center has been what we call UN-seq, which is a project where the entire genome in the tumor is sequenced, so that for patients who don't have treatments, we can identify additional markers that have drugs that work against them that may not have been approved necessarily yet for melanoma, but for other cancers. And so we're trying to offer new options for patients where maybe no options exist. Another focus has been molecular diagnosis, because some of these markers are useful on a molecular level because they're not found in moles. And so we're looking at change that doesn't change the DNA coding, but it changes what genes are turned on and off by what we call methylations on certain parts of the DNA. So we're using that now for diagnosis, and we've pinpointed a particular subset of methylations that are useful for diagnosis. My favorite part of my job is when I diagnose a melanoma early. When I find it before it's spread, and when it's a thin melanoma and it has a very almost negligible chance of spreading, I think that's an important contribution. And so finding those early is my specialty. It's something that I seek to do. It's something that I work to become better at all the time. So I chose to specialize in it because I wanted to care for the patients psychologically and medically, and also to do research in the area so that we could try to find new options for patients.